Hi there, Ashley. Hello.
Hi, how's it going?
Hi, Dr. Stone. We can hear you.
Which one can you see me on both?
Well, hello, everyone. Welcome to this evening's community lecture in collaboration with Albuquerque Academy and the UNM School of Medicine. First of all, I just want to thank you all so much for being here and attending this evening and for making space in your life for this very important conversation, engaging with us in a virtual community lecture about eating disorders and disordered eating. The challenges that Dr. Sauer is going to speak with us about today, they give us an opportunity to support one another. And so we're grateful for that opportunity. And we're going to discuss these and our collaborative health tonight. So quickly, I want to make mention of the community lecture series. It was established in the fall of 2015 at UNM as a way for the School of Medicine to extend its mission of supporting the health of all New Mexicans. And so these lectures bring accessible knowledge to you, the community that we serve. And you can watch all of the past lectures that we've had at the community lecture series lineup online, thanks to our partnership also with the city of Albuquerque. And of course, Albuquerque Academy has been so gracious in the past to allow us twice a year to come onto their beautiful campus and do this event live. And now twice they've collaborated with us to host a virtual event in the world that we're living in. So we're very thankful for that collaboration. And want to remind you that we do this regularly. We'd love for you to come back time and time again. So thank you to the Academy. Tonight's lecture from Dr. Sauer is going to include about 45 minutes of lecture time, as well as a question and answer session at the end. Many of the questions did come in ahead of time, and we thank you all for submitting those questions if you did. Dr. Sauer is going to do her best to answer questions during the lecture. And then we also have some that I will moderate after the lecture. And feel free to use the question and answer feature on Zoom to submit additional questions that may come to mind as she goes through the lecture. And Dr. Sauer and I will do a little bit of that conversation at the end. We'd like for you to join us through that question and answer feature. And of course, remember, if we don't get to all of the questions, we will do our very best to follow up with you in response after, as well as to provide everyone with a link to the recording of this session and any resources that Dr. Sauer may share with us. That being said, I'm going to go ahead and welcome Dr. Mauricio Towen, who's going to introduce Dr. Sauer for us. Now, Dr. Towen is a distinguished professor and the chairperson for the Department of Psychiatry and Behavioral Sciences, and he is also a proud Academy dad. So go ahead, Dr. Towen.
Thank you, Ashley. It is my honor to introduce Dr. Sauer today. Dr. Sauer is on the faculty of the Department of Psychiatry and Behavioral Sciences. She is the director of the training program for child adolescent psychiatry, and she's also the leader of the eating disorders program. We couldn't have a better speaker than Dr. Sauer tonight for two reasons. Number one, she is an expert in eating disorders. Number two, she's an excellent speaker, and she's committed not only to training of future providers, she's actually committed to training, teaching, sharing ideas with the community. So that's why we couldn't have a better speaker. So Dr. Sauer, my honor to introduce you.
Thank you so much, Dr. Towen. It's an honor to have you introduce me and to be here. And I really appreciate you making time with your clinical schedule as well. So thank you. And thank you everyone for joining tonight. I realize that people have many evening opportunities and things going on. So we hope to make the most of your time and that this is an educational opportunity. And I certainly, my contact information will be included. As Ashley had mentioned, I'm happy to continue this conversation beyond the talk too, but hopefully this is a helpful introduction and just sparks a little bit of conversation around the topic. So I will go ahead and share my PowerPoint and we'll get started. And so I do hopefully have a fair number of pictures and some other things to try to keep it a little bit more active. Okay, so the title, as has been advertised, on disordered eating, recognizing the illness, realizing the danger, and responding for New Mexico. And as Dr. Towen mentioned, I'm in the Department of psychiatry and child and adolescent psychiatry at UNM. So I wanted to start with this slide. First of all, again, to thank you all for joining, and just to take a moment to realize that, I think each of us has the opportunity in our own lives with people that we care about, in our bigger community, to make a difference, and that together we can all help make change. And so I think that applies to many things in mental health, but especially with eating disorders, where we realize that in the state of New Mexico, there is still a lot, I think, to be built and to be kind of collaborated upon in improving care and support for people. Okay, so the objectives for tonight's lecture, we'll go through some of these points. So the first is talking a little bit more about what disordered eating is. The prevalence of it, the impacts, both statistically and kind of on an individual level, and then talking a little bit more about the etiology, or what we think contributes to the development and causes of an eating disorder. And then we'll review the formal types of eating disorders, also talk about disordered eating in a broader context. And then we'll talk about some common warning signs or symptoms, behaviors that people may demonstrate if they're suffering from an eating disorder that perhaps other people pick up on as part of the picture. And then we'll talk a little bit more about assessment and treatment, and go into some depth for those of you with a medical background in this area too. And then, as mentioned, questions and answers at the end. Disclosures, I don't have any relevant financial disclosures to this talk today. I mentioned I'm employed at the University of Mexico, and previously did work at the Eating Disorder Treatment Center of New Mexico, which is an excellent treatment center for individuals with New Mexico. And we'll touch on that a little bit at the end when we speak about resources. So I think the timing of this talk is very relevant. Perhaps some of you have seen in the common media, in the news, and to some extent in the medical literature, there has been an increase in people developing or experiencing eating disorder symptoms over the course of the pandemic. People with a history of an eating disorder sometimes having increased symptoms or relapses. And that's probably related to the stress, and that sometimes turning to food or behaviors around food can be a coping mechanism when so much else is out of one's control. And then I also like to point out that sometimes eating disorders are generalized, or there's a stigma about them where it's, only affects Caucasian, higher socioeconomic status individuals. Sorry about that, individuals. And so that is not the case. We know that eating disorders affect people of both genders, transgender individuals, all ages, all ethnicities, backgrounds. And so I think, living in New Mexico, given the diversity of our population and just in general, this is a really important take-home point. Okay, so a couple things, and this was a consideration as far as polling, but I'm actually just gonna ask you all to reflect upon this. So for those of you in the audience who has had a family member or personally been affected by an eating disorder, and if you know where to turn if someone has an eating disorder, these are points that we will touch on more shortly. Okay, so I wanted to share a few kind of statistics and talk about the impacts of eating disorders starting out. This graphic, I think, incorporates a lot of important points. I know some of the text gets small, but I'll just walk through it. So on the upper left, about 10% of the US population will have a formal eating disorder at some point in their lifetime. So that's almost 30 million Americans. It also actually has the highest mortality rate of any mental health condition, aside from overdoses related to opiate use. So that surprises a lot of people. Often they think of other conditions like bipolar, schizophrenia, depression, but specifically anorexia has the highest mortality rate. And as mentioned, eating disorders affect everyone, all ages, all races and ethnicities. And unfortunately, people who are not of Caucasian background tend to be less likely to be fully assessed and receive adequate treatment. And then there is a tendency that eating disorders affect females more than males, but it's not by any means only a disorder that affects females. Many men, boys are affected. As mentioned, many individuals who identify as transgender as well. And so I think it's important that we highlight that. And then this is just a cost breakdown. So if we look at the billions of dollars as highlighted here, mixed between the medical costs, the kind of loss of productivity and quality of life that people experience, these are very substantial disorders as far as impact. And then if we think about in New Mexico, so if we translate some of the statistics, it's approximately 200,000 people in New Mexico that will suffer from an eating disorder at some point in their life. And when we think about the prevalence, which is that about 1% of the population suffers from anorexia, about 3 to 5% with bulimia, and maybe 4 to 5% or more with binge eating. These are some of the numbers of the people in our state. So it's a pretty large, large population, and unfortunately, a lot of people who are not ever formally diagnosed. And again, we know in New Mexico that we have somewhat limited resources, and there is, across the board, an increase in other healthcare issues, morbidity, and as mentioned, an increased risk of death associated with these. So again, kind of setting the stage for why it's important for us to pay attention to disordered eating. Okay, so that's on more of a system level, and then individually, when we think about the impacts that disordered eating and an eating disorder can have, it crosses the spectrum of our experiences as humans. So from a psychological angle, eating disorders can exacerbate underlying mental health issues such as depression and anxiety. And then sometimes they can also cause additional symptoms. So for example, if someone's really restricting, it's not uncommon that they develop depressive symptoms as well. Usually it's tied into people struggling with their sense of self and sometimes getting to the point of having more thoughts of self-harm or suicide. Medically, eating disorders are what we call psychosomatic conditions. So they affect certainly the mind, but also the body. And the effects on the body can be widespread, sometimes life-threatening, and sometimes irreversible in nature. So it's a very important preventative health consideration. And then from a social aspect, there can be a lot of impairments that people suffer with relationships, especially given that culturally food and, connecting with people over meals and such is an important part of our connections. It can also impact developmental trajectory for children and adolescents who are, looking to launch into their adult life. And there can be impairments in one's ability to partake as they would like in work, in school, and also with extracurricular activities. And so I think all of this, as well as some data we have about what the value of intervention can be in preventing longer term consequences, is really another important thing for us to think about. Okay. So we've talked about the number of people that suffer from disordered eating and the consequences, but as mentioned early on, maybe less than half of people with disordered eating seek help or gain formal help. And so why is that? And there's, several different reasons probably, but the first couple I'll point out is that, as mentioned, historically, there's been some negative stigma around a lot of mental health conditions, and eating disorders is often included there. And then many people feel a sense of shame, and so they may not want to disclose this openly. There's also the consideration that in some ways an eating disorder is kind of socially and culturally reinforced, and so maybe not seen as much of a problem, right? It produces results that someone's trying to seek, and often is a coping strategy that people may not want to let go of. And then again, many people don't know what an eating disorder is or how to seek help for it, and there's not always great access to care. So these are some of the barriers that we tend to think about with working with people with eating disorders. Okay, and then I want to take another step back here and think about, well, what defines disordered eating, and what's the difference between disordered eating and an eating disorder? So this graphic here encapsulates some of the things that we think about. So if we're at the upper end here and we're considering someone who might be more healthy on the spectrum of eating, they'd be someone who values healthy eating as far as putting good nutrients into their body and taking care of themselves, but they're flexible with eating. They can adapt to different social environments. They have confidence in their body and their body image or who they are, right? No one, I think, would be considered in the, seeing themselves as perfect realm here, but just kind of an acceptance of where they are in the world. And then as we move down the spectrum, we see that, as people become more preoccupied with food or dieting and have increased dissatisfaction with their body, kind of perseveration or obsessions about needing to change their body, and really the strong connection between body image and who they are as far as sense of value or worth in the world. Those are all pieces that we start looking at as more eating disordered patterns. So this slide again encapsulates more of what I had just mentioned. Also, sometimes you see that people develop very excessive or rigid exercise routines, behaviors like obsessive calorie counting or having a very rigid approach to eating, and using food or the lack of food as a coping mechanism. So I know that, many people, and there's a lot of press and media coverage around certain types of eating, certain types of dieting, and the proponents of that being, a very important approach for health. And again, what we're talking about today is generally focused on where someone's at with regards to the anxiety that they have about eating, how they use food as coping, and what their relationship is with their body. So these are a few examples of eating disordered thoughts. So when people mention like, I can only eat clean foods and I have to eat at certain times of the day, and if I vary that, I get really stressed out and I feel guilty and I feel like I want to binge. So kind of that whole mix of thoughts and then kind of negative emotions. Really intense fixation on exercise. I have to go to the gym every day for at least an hour. And if I don't, then I'm going to incessantly worry about my weight and feel like I can't control my appetite the rest of the day. And then this just negative self-image again, of I can't stand how I look, I can't wait until I lose another 20 pounds to feel better about myself. So again, not one of these thoughts individually, is per se the definition of disordered eating, but these are kind of along the spectrum. And then when we think about why people develop eating disorders, this pie chart, I think, nicely summarizes the different factors. So if you look at the bottom half, we see that genetic predisposition and having kind of a vulnerable personality put people at higher risk. It might explain why some people who live in the same society and are exposed to similar stressors develop an eating disorder when other people don't. And also on the bottom panel there, we see mention of family functioning style, as well as major life changes or trauma. So those can all kind of set the stage or be triggers for the development of an eating disorder. And then in the top, we think about the social influences around dieting and sometimes peer or relationship concerns. And again, here reiterating that a lot of people develop eating disorders as a coping mechanism. And sometimes it's in, pursuits of health. Sometimes it's in pursuit of a certain appearance, but it often boils down to some of these pieces. Okay, so then a few slides just thinking about, again, societally and culturally, how we view weight, how we view food, and thus how, it can influence the development of disordered eating. So this first slide here, recognizing that medically and from a health stance, we know that there is some importance and value to looking at, how healthy of a diet someone is eating, how are they balancing their nutrition, what is their overall health, and where in ways is that connected to weight or metabolism. So we talk about things like obesity as a global pandemic, ways that diet and nutrition can be helpful for our health, and then ways that we measure, BMI, body mass index, or weight when we're looking at different health outcomes. So some of this certainly has a place that we know is important from a medical angle, but then when you look at kind of the different layers of how our society also accentuates, diet and appearance and food, these are some examples. So the idea that when you look good, you feel better, that losing weight equates with happiness, these frequent images of kind of the ideal fit body or what people strive for. Different ads or, this People magazine cover about people feeling a pressure to be thin. Here's an example of an advertisement for weight loss surgery for people that are slightly overweight. And then these were just a couple screenshots looking at like, kind of celebrity news off of social media feeds. So just a lot of focus on body, on weight, and again, both genders here. And then we see so much advertised around, this diet is ideal. And do I do paleo or do I do keto or Atkins? And what's going to help, me achieve the most ideal health and weight? And then social media. So many of our, young people are spending a lot of time on social media, and there can be some positive influences, but also can be some pretty intense pressure around ways of eating or intake or how people look. So this slide, I think, encapsulates as well the way that societally we focus on body image sometimes and how that affects young people. So there's a lot of statistics in here. I won't go through all of them, but it does highlight from various studies that many young individuals, and this includes, again, both girls and boys, tend to become focused on their weight. They put a lot of priority on it, and thus, have a degree of pressure on feeling like they need to achieve some ideal. Okay. And then in addition to those pieces, we know that there's components of just the way that food and exercise exist for us day to day that make it more feasible for us to turn to these as coping. So it's easy for us to access food in our society, and especially food that people might consider comfort food. Many people develop patterns of turning to food, or they might call stress eating, in times of boredom and times of higher stress. And that for many individuals as well, there's a consideration of food insecurity. They grow up in an environment that they just don't have access to food. And so as they get older, sometimes that fear of not having food and attachment to food is an important piece. And then being able to control food or exercise, becomes a coping pattern for people, as well as dealing with anxiety about themselves, especially about bodies and how somebody feels like they should be. Okay, and then just an additional point linking back that we do know from research, there is some connection with genetics. Eating disorders tend to run in families, and there's several genes that they've been looking at, especially around neurotransmitters that are connected with eating disorders. Epigenetics, or the way that our genes are modified based on our environment, seems to also play a role. And then for people with eating disorders, when they look at their neurobiology, for example, by imaging scans, they can see that some people with eating disorders just seem to have alterations in the way their body responds to food as a reward, or the kind of inhibitory experience when they're full. And so in some realms, people are also looking at as food similar to other addictions in this regard of behavior. So I think certainly evolving research in this realm. Okay. And then we'll also talk about additional risk factors for eating disorders. So I mentioned more common in females and people that identify as transgender. People that identify as non-heterosexual also are at higher risk. And then most commonly seen in adolescents, as well as the middle age group, and people with a family history, a history of trauma, or folks who identify, who are in the spotlight, or athletes tend to be at higher risk. Okay. All right. So that's kind of the intro to the background on disordered eating and what puts people at risk. Now we'll spend a little bit of time here talking about formal diagnostic criteria. Many people have an idea about what these eating disorders are, but I'll just talk about how they're formally diagnosed. And then these bottom three, pica, rumination disorder, and unspecified feeding and eating disorders, these are a little bit more nuanced, and they're considered in the psychiatric category of feeding and eating disorders, but I won't touch on them tonight. Okay, so anorexia is formally defined as the restriction of energy intake that leads to low body weight. People also have a sense of their self that's strongly correlated with their appearance, and usually a distorted body image, as this photo reflects. People develop often medical signs of starvation, and they need to have symptoms for at least 3 months. Often we think about people with anorexia nervosa as those that restrict calories significantly and exercise a lot. But people with anorexia can also binge and purge their intake The difference between bulimia and anorexia then is that if someone's at low body weight, they would be considered to have anorexia. And we don't use BMI, body mass index, to formally diagnose anorexia, but we do think about it in terms of grading the severity of illness. So many people with anorexia will present as thin or having weight loss, but they'll often try to hide their weight. They may avoid meals, eating with other people, and just in general have a limited intake and often an increased intensity of exercise. Some physical symptoms that you see can be people that feel cold all the time, development of lowered heart rate, low blood pressure, and being more prone to fractures. And many people with anorexia have concurrent mental health conditions, including anxiety, obsessive compulsive disorder or tendencies, and then mood disorders. They often develop additional medical complications due to malnutrition that we'll talk about. And this one, anorexia, at least from the research done, is much more common in females than males. And again, to mention here that early recovery and getting people out of the cycle of significant restricting and back to a better point of health, both in terms of intake and weight, can be really important for recovery. There's a newer eating disorder diagnosis that's included in the DSM-5, the newer psychiatric manual. And I just want to mention it here because we see this not uncommonly. And it is defined as people having a low nutritional intake that leads to nutritional deficiencies or failure to gain weight as appropriate or weight loss. But they don't engage in compensatory behaviors and they don't have associated body image issues. And so this is a little different. And it tends to be when people have significant anxiety about food or about eating, people maybe that had a traumatic event around choking or something and then really change their eating patterns. And they may also have sensory issues like aversion to certain tastes or textures. So this one, medically sometimes presents as children or adults with weight loss and difficulty with intake, but they don't have the congruent body image issues. So then I'll move back to another eating disorder though, where body image is a major part. So bulimia, another common eating disorder, is defined as when an individual is binging. So eating in a discrete amount of time, about 2 hours is the definition, significantly more than most other people would in that time. So binging and then purging, getting rid of that intake by some manner, at least once a week. And again, having the negative sense of self or sense of self that's strongly correlated to body image. And here being more in the normal or elevated body weight. I've intentionally included some pictures of men or males here because it affects a fair amount of men, but sometimes it's seen more as part of gym culture or sports related, even though it is technically bulimia. This is a slide looking at how people purge, and most people engage in self-induced vomiting, but also a fair amount still use laxatives or use other means of purging the content that they've taken in, such as diet pills. And then common signs with bulimia can include things like someone who goes to the bathroom frequently immediately after meals. People may develop significant dental issues, enamel erosion because of frequent gastric acid in vomiting. They might have gastrointestinal distress, and then you can see fluctuations in their weight. Sometimes again, preoccupation around exercise as a way to purge. And then physical signs I've shown on the right. So the bottom right, Russell's sign, we call it, is some scarring on the knuckles from self-induced vomiting. And then the upper right, people can develop a swelling of the parotid glands that are there on the side of the cheekbones with frequent purging. So I'll just come back to, it's very common that people with eating disorders have another concurrent or multiple concurrent mental health conditions. So they may often have issues with mood dysregulation, sometimes other impulsive behaviors or self-harm tendencies. Many medical complications can be possible, often related to purging behaviors. This one is a less, there's more of an equal spread between males and females here. And then some people actually develop a bit of an addiction to the purging part of bulimia, where they purge not only to get the food out, but because purging really leads to a release of endorphins in a way where they feel better in multiple layers after they purge. Okay, and then the last major eating disorder, I've talked about anorexia, ARFID, bulimia, and now binge eating disorder. So binge eating disorder, kind of on the spectrum of bulimia, where people binge, again, eating an excessive amount in a discrete amount of time, usually accompanied by these feelings of guilt, remorse, or feeling out of control when they're eating, at least once a week for at least 3 months. And they're not engaging here in compensatory behavior. So they're not purging, and thus they often are overweight or at higher weight because of the increased caloric intake. People with binge eating disorder, you may see some isolation around meals, sometimes purchasing of large quantities of food or disappearance of such. And then often, again, the increased weight and medical complications with that, and often mood and self-esteem issues. So similar to here, mental health conditions, I'll point out that there is an increased incidence of ADHD, attention deficit hyperactivity disorder, in people with binge eating disorder, as well as mood and anxiety conditions. Many medical complications related to obesity and metabolic concerns. And then this seems to be a more equal split amongst genders. And it's not uncommon that people will be presenting to medical weight loss clinics or for gastric bypass surgery, and they have a history of binge eating, but maybe just really haven't been adequately assessed for some of these behaviors contributing to their weight. So one slide to think about from kind of a provider standpoint, is someone primarily struggling with an eating disorder, or do they have another mental health or physical condition that's then causing symptoms that look like an eating disorder? So there's not infrequently a consideration of anxiety disorders that affect one's eating, mood disorders such as severe depression, psychosis, people that may have neurodevelopmental disorders like autism or other medical conditions. So I think usually where the differentiation can be made is around the core root around the eating behavior. So is there a lot of anxiety around food, a lot of anxiety around one's body image, and using food or the lack thereof as coping that can help in distinguishing kind of chicken or the egg here. But sometimes it is complicated. And as I said, people may often have more than one condition. Okay. So often people will say, I think my daughter, I think my sister, I think someone I know may be struggling with an eating disorder, and I'm not sure how to approach them. So I've included here just a few ideas, transitioning from like the formal criteria into more of an evaluation, or just opening the door to talk about this. So sometimes just being able to make observation comments, observing someone's behavior or observing changes in the way that they're acting can be helpful, such as, I've noticed that you're not eating meals with the family anymore. Can you tell me a little bit more about that? Sometimes validating as well the pressure that might exist societally on us, validating the shame or the fear that people might have in talking about having an eating disorder. And then also vocalizing concern for someone's health. I'm worried about you. How can I help? What can I do to get you some help? Can all be some options for getting a foot in the door. And then I think for people that are working clinically with clients and patients, these are some questions that I've learned and that I often use to help, again, spark a conversation. So can you tell me about your relationship with food? Do you use food or exercise as a coping mechanism for other feelings that you're having? How's your relationship with your body? And then are other people worried about your eating, or have other people, expressed concern about weight loss or weight gain or things like that? So these are just some jumping points. And then when someone has an eating disorder, it's important that we're looking at the bigger context of their life and figuring out, how do we help them? How do we make sure that they're getting enough support? And at what point do we potentially need to push into more medical or more mental health help? So it's good to get more of a history as far as what kind of mental health conditions someone's had, what their medical history is, and then have they had an eating disorder before, or what kind of behaviors have they demonstrated? I think it's always good to know what someone's social context is. Are they working? Are they in school? You know, are they having to take a break from those things? And what's their family structure? And then what kind of physiological and psychological symptoms are they experiencing? You know, do you feel lightheaded? Are you having a lot of feelings of nausea when you eat? Are you feeling really anxious around food? Things like that. Sometimes getting a history of current stressors or prior trauma can also help in understanding how someone develops or reinforces eating disorder behaviors. And then people with eating disorders are at increased risk of having suicidal thoughts. So asking about self-harm or safety considerations. And then many people also, in addition to an eating disorder, will have substance use concerns, alcohol use, cannabis, stimulant use. And then talking a little bit about how well does someone understand or see their condition, and how motivated are they to change. So these are all really important in kind of getting to know someone more holistically. And again, the support structures. So some people may have really isolated themselves, and some people may live in family setups where there's almost a pattern that contributes to the continuation of the eating disorder. So that can help in framing the kind of care people need. And I mentioned this safety piece. Okay. So those, I think, are helpful considerations in evaluation. So as you get the sense, or if someone you're working with, you know, you think has an eating disorder, then let's kind of imagine now what, right? Like, where do we turn, or what's the most evidence-based or appropriate care? So multidisciplinary interventions for people with eating disorders are really important if they're available. Therapy to work on some of the thoughts, some of the coping patterns, those kind of processes can be key, both individually and sometimes for families, especially for adolescents. Occupational therapy I'll talk about, as well as more nutrition support, medical and psychiatric care. And then there's various levels of care for an individual with eating disorder behavior. So many people might be at home doing kind of outpatient care, right? Going to a visit a couple times a week. But if the eating disorder becomes more entrenched, or someone's having more complications, especially physically and medically, they might need a higher level of care, potentially being in a residential or inpatient center for a while, or some level in between. So I'm just going to spend a little bit of time talking about that last slide. So with regards to therapy, there's some therapies that have been researched and we consider to be most effective. That includes cognitive behavioral therapy that works on some of the thoughts and behaviors with eating, as well as family therapy, especially for adolescents. But there's many other types of therapy, perhaps as you all have been exposed to, such as dialectical behavioral therapy, other body-based therapies that we think and have seen evidence can be helpful. They just may have not been researched in quite the same level. With regards to nutrition, this can be really important for almost giving a little bit of external control over eating. So a nutritionist, especially one who's trained in working with people with eating disorders, can really work with an individual to determine what their needs are, what their goals are, and how they can best get there. They can help in monitoring these goals. They can counsel around anxiety or certain types of avoidant behavior with food, and collaborate with other team members. And then I know we've had questions in the past about occupational therapy. And so I think it's worth bringing up here that in addition to these other types of therapy, occupational therapy can also be helpful in giving people an additional structure to resume meaningful activities and consider where the eating disorder is causing impairment and what kind of things someone needs to do to be able to return to things that have meaning for them. And as mentioned, there's several different approaches here that occupational therapists use in this regard. And then medically, it's really important, I think, to have at least an initial evaluation and often to have ongoing follow-up. So medical providers or professionals can help with monitoring the basics of how someone is functioning, especially as reflected by vital signs and one's weight. And then they can help again in tracking for progress, and then importantly, evaluating physical symptoms that might come up. Medical providers might order some of the following: physicians, other individuals who are working from the medical side. These labs are very commonly done. So a complete blood count, a chemistry panel to look for electrolyte disturbances that can happen as with purging, evaluating someone's thyroid function, liver function, their lipid panel, some of the other tests mentioned here. An electrocardiogram or an EKG at baseline can be very helpful to know the state of someone's cardiac function. And then I've mentioned a DEXA scan here as well, because sometimes people with restrictive eating disorders are at higher risk of losing bone mass because of the poor nutrition. And so it can be helpful to track that. So these are some different pieces, and certainly for those of you in the audience who are working from a medical angle, I'm happy to be a resource or provide more feedback on kind of how these can be monitored, or maybe best practices in doing so. And then I know we're getting close to the time. I just want to share a few minutes on some of the medical complications that happen with eating disorders, because I think it's, you know, sometimes again provides a little bit more emphasis on the need to look for and evaluate and identify people who need support with eating disorders because of some of the significant physical issues. So people with anorexia, they lose muscle in many parts of their body with weight loss. They can also have actual loss of cardiac muscle that can affect heart function, and then you can see changes in blood pressure. People with bulimia, because of the purging and electrolyte changes, can develop arrhythmias. Many people with eating disorders, because of some of the pieces I just mentioned, are at somewhat increased risk for sudden cardiac death. And then with binge eating or the higher weight metabolic concerns, you can see some of the metabolic syndrome picture. Sorry, this one's coming up a little backwards here. Okay, so from a gastrointestinal perspective, many people with eating disorders experience distress in their GI system. So they may explain feelings of heartburn, nausea, changes in their bowel movements, and that can be related to the experience of changing one's eating habits or purging. But you can also see changes in how effectively the GI system absorbs food, absorbs medications, and as mentioned, sometimes electrolyte changes that can have other downstream effects. And then I like to mention here as well, one of the major considerations with anorexia, and you can see with the restrictive eating disorders, is loss of bone mass. People may often, especially women that lose their periods and have hormone changes with that, are at increased risk of losing bone mineral density. And that can perpetuate for many years, if not decades, after even recovery from an eating disorder. People with other eating disorders, though, can have other endocrine changes. Increased cortisol is often seen, which might be related to stress on the body, sometimes related potentially to prior trauma, but you can see changes from an endocrine system as well. Okay. And then the last piece here, so just thinking about from a psychiatric angle, when people have an eating disorder and they're trying to get that full spectrum of care, that sometimes medications that help with mental health can be helpful. There is no medication that works just on an eating disorder. It tends to be helpful for other symptoms associated, like mood, anxiety, sleep. It's important to keep in mind that just having alterations in nutrition, such as really poor nutrition, can affect mood by itself. And as mentioned, you can have these changes in absorption, and sometimes people maybe have different levels of compliance with medication, especially if they're worried that it will affect their weight. We had some questions, and so I just want to point out in these slides that for some of the different conditions, anorexia or ARFID, antidepressants might be less helpful, especially if they work on serotonin, because you need dietary intake of other amino acids such as tryptophan to be able to make serotonin. And so sometimes antidepressants are not as helpful in an active restriction process. And we look at other medications, such as mentioned here with the atypical antipsychotic class or other meds that treat anxiety, especially around food. And there's certain medications, I mentioned one here, bupropion, that has an actual indication that it should not be used when someone has an active eating disorder because of the risk of seizure disorder. For bulimia, there's evidence on using fluoxetine, which is an antidepressant, to reduce binging and purging cycles. Naltrexone is one that's commonly used actually for opiate and alcohol use, but can reduce urges to binge and purge by reducing some of the kind of reward pathways that develop from that kind of endorphin kick. And then other medications like topiramate that affect potentially reduce the urges to binge. As mentioned, we need to have caution about certain kinds of medication given other medical complications from bulimia. And then with binge eating disorder, so antidepressants have been shown to reduce the episode or the frequency of binge episodes, not necessarily impact weight. Topiramate is a mood stabilizer, as mentioned in the last slide, that can sometimes reduce binging. And then stimulants, as used for ADHD, such as lisdexamfetamine, which was FDA approved, can reduce urges to binge and purge. So these are all medications that we use. Again, I think, a lot more depth that we can go into there. But I'll conclude then in this very broad amount of content on eating disorders, talking a little bit on how can we think about helping support, our community and people that we care about in pursuit of healthy relationship with themselves and with food. So I think there's an importance around the mindfulness and the way that we speak to others about their weight and their eating patterns and body image. So just having the awareness of, that for some people, this is an area of a lot of sensitivity and sometimes shame. There's movements about promoting health in different ways. So health at every size, where it becomes more of a focus on helping people be healthy and how they can be their best self, kind of regardless of what their BMI is, so to speak. Promoting balanced eating, activity, mindful eating, and then just in general education about our health from both, a basic nutrient level, but also the psychological relationship we have with food and with our body. So then last slide here on some resources. I do have a clinic, as mentioned, at UNM, and I'm happy to see people, especially from a psychiatric angle with eating disorders. The Eating Disorder Treatment Center in town is a great treatment center for people with eating disorders. They also offer an intensive outpatient and partial hospitalization level of care. We have many therapists and nutritionists in town with some expertise in this area. And then we don't have residential or more intensive inpatient level of programming for people in New Mexico right now. And so there are many other residential and inpatient treatment centers regionally. And during COVID, many places have gone to virtual programming, so more is available to people at home. I've included here as well there's a lot of online resources. I think these can be really helpful in education, information, support groups, etc. So I'll share these, and then just a general, again, message at the end about, we all play a role, I think, in supporting each other. So I hope this content's been helpful. I know there's a ton of space to cover in eating disorders, so I'm happy to field some questions, and again, to be available for further contact by my email. Thank you.
Well, thank you so much, Dr. Sauer. That was really wonderful. And it was a broad look at so many pieces of these disorders. I really appreciate that you took the time to explain that to us and to make space in all of our lives to learn about it and to support others. And I think that there are a few questions that have come in the chat, as well as some questions that we received ahead of time. And so we want to move into that section of our event where we encourage the audience to ask those questions if there are more that haven't been submitted. Use the Q&A feature. And we are going to be sharing the resources that you shared, Dr. Sauer, here for everybody who attended, as well as those who registered and weren't able to attend. So we'll send out this link to the recording, as well as that resource sheet for those of you asking. So I'm going to start with one of the questions that we received ahead of time. And the first one that came in was, are there distinguishing features of disordered eating between males versus what you see in females?
Yeah. Yeah, and thank you to everyone who submitted questions. I really appreciate the thoughtfulness. So it's a great question, and as mentioned, historically, maybe there's been more focus or people look for eating disorders more in females. I don't think necessarily distinguishing features just based on gender, so to speak. I mean, I think that both genders, and again, transgender individuals, face certain pressures or may feel certain pressures societally on how their body should look or what the ideal goal is for them. And so we see people that turn towards modifying their eating or exercise in ways with this. And then again, in terms of coping and whether that's restricting or overeating, it can look very similar between men and women. I think sometimes culturally it's becoming more common that women or females open up about it and males perhaps not as much, but again, the landscape is changing. So yeah, I think there's more or less a lot of similarities between males and females.
Thank you. A second question that came in, and I think some of the questions that came in are, there's a lot of stereotypes out there, and you definitely raised some questions about those. And this one is, how has the pandemic informed, is there any relationship between heavy use of cannabis and disordered eating?
Yeah, so that's a good question. There, as mentioned, a lot of people have concurrent substance use issues. And so sometimes it's chicken or the egg. So it's not uncommon that people with eating disorders may feel like cannabis helps them feel more calm, and then they are able to actually eat in a more kind of relaxed pattern because of that. I think with regards to cannabis as kind of the chicken, we don't know a lot about, relationship. I mean, there's the common adage that cannabis contributes to the munchies or people wanting to eat more, but there's not been a lot of data on that. I just would, again, share that for those of you working with people who might have eating disorders, it's pretty common to see that link with substance use, in part sometimes as a way of coping with the eating disorder, that the substance use contributes to that too.
And we had a question come in from the live audience. It says, you mentioned some are starting to look at eating disorders as an addiction. Can you say more? What are your thoughts on Overeaters Anonymous?
Yeah, that's a great question. So I guess what I would say is that there's more research or more interest in this field as considering the link that some people have with food as an addictive behavior. Some of the imaging studies, for example, suggest that when people eat, it might light up in certain areas of the brain that are involved in reward feelings, as you see with other substances. And you also can see this similar drive and kind of the psychological attitude towards food that people develop with addictions to other things too. The challenge, of course, in other realms, substances, some behaviors, you can decide I'm just cutting this out, like, abstinence is the best policy. And we know it's a lot more complicated with food since we all need to continue to eat for nourishment. So yeah, definitely a really interesting area of further research. And Overeaters Anonymous, the 12-step approach, I think as for substance use, for some people, that 12-step approach is awesome. And I think a great way of working on the behaviors and some of the emotions or the processes around these behaviors that can help in recovery. And a lot of people like to include Overeaters Anonymous with like some of these other services that they're doing, because the support group itself may not be quite enough structure, but certainly can help with a sense of kind of identity or, connection with other people that are also suffering with similar experiences.
You touched on the pandemic a little bit when you first got going, and someone asked ahead of time, how has the pandemic informed not just our acknowledgement of maybe eating disorders, but the treatment of eating disorders?
Yeah. So I think the way I would answer this most succinctly, I think, is that as with other types of medical care and mental health care, a lot has moved virtually, which hopefully has improved access to and ability for people to seek care. So there's that component where, the different treatment centers I had referenced briefly, for example, now have moved to virtual. So hopefully there's been an expansion of services. I think, though, the other piece that we've also seen that's a little different is people may be experiencing more eating disorders when they're at home. But, I think also for like adolescents, for example, we're seeing that as we return to more in-person visits, people seem to be talking more about the eating disorder experiences when they're directly in person. So I'm not sure if sometimes the care that we've delivered virtually, especially if adolescents are around their family members and such, people may not be as comfortable disclosing that around others. But yeah, it's definitely been an evolution this year as far as care delivery.
It's impacted our offerings as well. For this, for example, I know there are people out there today who wouldn't be able to join us in person. So virtual has its upsides. So you'll have to excuse me. I'm not familiar myself with Prater, Willie, Eller, or Danlos, but someone says, what are some medical mimics or specific medical conditions worth evaluating, such as the 3 that I mentioned?
Yeah, so that's a really important question. I know I didn't touch too much in depth on that, but there are some medical conditions that I think are important to have evaluation for, kind of ruled out, especially if someone's presenting with a lot of physical symptoms in addition to some of the eating or other behavioral changes. So Prader-Willi syndrome being a genetic syndrome where people have often just kind of an uncontrolled drive to eat. We see it presenting in younger kids since it is genetic, and thereby often also have struggles with higher body weight. So that, again, tends to be accompanied by other genetic kind of syndromal symptoms or signs that a medical professional would look for. And then Ehlers-Danlos syndrome disorder is another diagnosis that sometimes is missed. It can take some work clinically, I think, for people to arrive at that diagnosis, I should say. But there's more research looking at that condition, for example, and some of the changes that people have in sensation and connective tissue in their body, for example, that can affect eating behaviors. So I guess what I would say, those 2 specifics, but in general, I do think it's really important that a medical evaluation is performed. And along those lines, just to also recognize that many people with eating disorders sometimes have more focus on their body. They might be more sensitive to physical experiences. And that can happen and doesn't necessarily mean there's an organic or another medical disorder causing it. It can be related to anxiety or other psychological functioning. And so, yeah, it's complex, but often with these other medical conditions, there's additional pieces beyond just the eating disorder patterns.
Well, thank you. And we have some questions from many individuals who work in a healthcare setting. One from our occupational therapy program who asked Dr. Sauer, are there any occupational therapists that currently work with you at your clinic?
No, it's a great question. So if I am open, we are building our services, hopefully day by day, month by month, and as mentioned, as a collaborative multidisciplinary approach. If anyone at UNM has interest, please feel free to be in touch. I've had great success sometimes referring to occupational therapists, both within and outside of our system, and like to bring it up because sometimes I don't think it receives as much attention as it should as part of the treatment plan. But yes, please feel free to be in touch with me if you're interested in that, please.
And you mentioned intermittent fasting. Is this a bad idea for people with an eating disorder?
That's a great question. So I think there can be a fine line of behaviors in the pursuit of health and when it crosses over into more disordered eating. So I think the challenge with intermittent fasting is that, again, generally it's there are some more strict boundaries around time of eating, and one's experience with that, as far as like, if I'm doing intermittent fasting where I'm eating between 11 a.m. and 8 p.m., but I have friends going out for breakfast, kind of like, is there flexibility in that? And more so, how much anxiety or how much other behavioral changes does one start kind of spiraling into, sometimes with getting onto a more formal diet? So I don't think it's a blanket no. Of course, there's more research being done at some of the health benefits with different diets. But I think a lot of it is, kind of what is the intention of that? Is someone developing other kind of preoccupations, again, around food or around their body image, that are impairing their life in certain ways? And as mentioned, like, how much additional psychological distress do they experience from getting into a new diet? And are they able to maintain that without getting into a pattern of kind of losing control and getting into a restrictive or binge purge cycle?
We have a few questions that have come in about how eating disorders are handled from different professional clinicians. So do you feel that enough is being done in the primary care setting to address and recognize disordered eating? I feel that many providers do not recognize or know how to address the topic, although they're often that first stepping stone to treatment. What kind of education or support do you feel would be helpful to raise awareness on disordered eating in this setting?
Yeah, I think it's a really important question again. So there have been some studies looking at how much training and education people in that have gone through medical school or other medical fields receive about eating disorders, and it's quite limited. So, for example, a lot of primary care physicians coming through their residency may receive less than 4 hours of time over a span of multiple years learning about caring for people with eating disorders. And sometimes the exposure during training to working with people with eating disorders can also be limited. So I say that because I think the more effort we can put into educating our healthcare professionals is really valuable. Again, because it's usually not for lack of care or wanting to support people with the services they need, but sometimes a lack of knowledge, and then what eventually also looks at a lack of time or difficulty with sometimes our primary care professionals having enough space to embrace both the medical and the psychological piece in depth during their visits. So hopefully more education, helping our primary care professionals with good referral sources within mental health, I think, are all really key. And again, hopefully having more primary care professionals that are able to also speak, to this topic and help increase awareness from that perspective too.
Thank you. One of our live audience members said, "Excellent presentation, Dr. Sauer, thank you. Can you say more about the interplay between ARFID and physical GI illness, including GERD and gastroparesis, and how to encourage progress with this population?"
Sure. Yeah, so the ARFID diagnosis is the shortest way, I guess, to say it, can be complicated because in ways it is a label or a diagnosis we can use to describe the behaviors that someone has around food that can be associated again with anxiety, and sometimes that's stemming from a history of illness or other medical physical conditions. So what I would say to the question is collaboration with, or having somebody with ARFID, jointly seeing a therapist or a nutritionist who has some expertise or experience with eating disorders can be really helpful. Because I think a lot of times the goal is determining how you can help someone achieve adequate nutrition for themselves, even if they have some other concurrent medical conditions that might be limiting. If they have really strong sensory aversions to multiple foods, again, just kind of problem solving with that. And then hopefully, eventually kind of processing through some of those, anxieties about food because of a history of pain, a history of medical complications, a history of sensory aversion, for example, so that someone can continue to gradually expand what their comfort zone is. Kind of that complexity of approaching from different angles can all be really important.
And one more from our live audience, and I think we probably do have time to catch a couple more from the early on group. You mentioned dietitians working at the EDTC. What role do dietitians play in helping people with eating disorders?
Yeah. So I think they play a really crucial role, again, because I think they can help in almost coaching in ways with an individual around where they should be at, what's healthy, how can they get there, if there's certain foods or food groups that they're anxious about or averse to, how can they cope with that. And then as well, I think by taking that role, it can sometimes remove some of the pressure around control that someone with an eating disorder feels, so it's like, well, okay, I'm going to work on eating this in part because I know that I need to, in part because I trust my nutritionist, dietitian, and this is what, I'm being encouraged to do. So I think it's a really important piece to the multidisciplinary approach. And yeah, I think for people who are dietitians, there is great variety of training around eating disorders, beyond some of what's covered in the standard education. And so I think the more people we have who have some knowledge of helping people with eating disorders, the better for our community.
And I think the point of the next question is that can start very early. The question is, how can schools best support healthy eating and student wellness in regard to eating?
Yeah, so there's probably a lot of things that we would love to see kids receive at a young age educationally around feelings and emotions and healthy coping strategies and such. But I do think that, having conversations around food, and when we talk about health with kids, broadening that to, again, a connection of like pursuit of health because they're taking care of themselves, because they want to take care of themselves, because they want to be their best, because they want to take the best care of the body they have. And I think sometimes trying to be able to balance that angle with the more rigid focus on concepts around specific calories or diets or things like that, that sometimes kids can get more oriented towards. And then I think anytime that in our schools we can, provide some positive approaches for children around helping them feel better about their bodies or themselves, all of that kind of negative self-worth can contribute. And again, I think providing more education to teachers, to counselors, to people working in the school around eating disorders and how to help students who they think might be struggling is another important piece to getting more people help that they might need.
And we have time for this last question, which is also about children, although actually it doesn't say specifically children. It says, how do I parent my daughter with disordered eating patterns, both under eating and considering gastric bypass as a solution?
Yes, so this, I think many parents find it challenging to navigate this topic. A concern, especially with an adolescent, who's developing their own autonomy, or sometimes maybe kind of pushing back more on parental suggestions or control, how you help monitor and reinforce health at that age. So I think what I would say is that one of the biggest pieces is just to continue to be, to reinforce your support, to reinforce your presence for them. And I think, again, not being shy too about also stating observations or stating concern too, because sometimes I think for many people with eating disorders, hearing things once, they may not really come around or be open about it, but sometimes continued presence. And then I would say trying to get additional help, seeing about linking a therapist or a counselor or a nutritionist, or just any way that you can find to, help your daughter connect with someone who, again, might have more professional experience in this way. that can be another point of contact, for them to link with. I think those are all good starting blocks. And, as an adolescent can develop more serious eating disorder behaviors and more medical complications, there does become a point at which time parents, I think, really need to just push and sometimes be more forceful about evaluation, especially medically if needed. But, at less intense levels, those are some of the ideas that we usually share.
Well, thank you so much, Dr. Sauer, for your time this evening. And I also want to take this opportunity to thank the staff of the Advancement and Alumni Relations Office, Erica Anderson and Ruth Morgan, and everyone behind the scenes for helping us to accomplish another virtual community lecture event. Thank you to the Albuquerque Academy for collaboration again. And thank you to the audience for being here and for submitting your questions both ahead of time and during the live session. Dr. Sauer, that was truly part of the UNM mission, which is to improve the health of all New Mexicans. And I think you did just that tonight. We'll share the recording, and so we'll reach many, many more. And I want to thank you for your time in doing that. I enjoyed myself, and I'm sure everyone else did as well. With that, we will leave you all, and thank you so much for being here. Have a wonderful and safe evening.
Thanks, everybody. Thank you, Ashley and Erica.
Okay, y'all, I think we're good to go. Thank you so much. Although I think I did cut that off really awkwardly at the end. I was like,